Biomedical Ethics and Humanities here in the School of Medicine, and we're delighted to see all of you here today. Dying in America is very different now from a half a century ago. Before the Second World War, death usually happened at home, often without any medical intervention. But with the bioscientific and medical advances that began in the mid-20th century and continue today, death has become medicalized. In hospitals, it became possible to extend life, sometimes for weeks or months. It became possible for some patients to be cured who would otherwise have died. But for many others, dying became a protracted process, and this was sometimes marked by suffering that resulted as much from arduous treatment as from the terminal illness itself. Through the last quarter of the 20th century, even as the legal and medical professions, medical ethicists, and the public began to debate ways to limit treatment and even to hasten death, it became generally accepted that all patients have the right to refuse life-sustaining treatment. Now, early in the 21st century, 5 states in the United States legally recognize and regulate physician-assisted suicide. So where do we stand on dying in America now, and where do we go from here? This Medical Center Hour on Dying in America is one of our History of the Health Sciences presentations, and as such, it takes a look back at this critical social and medical issue, and does so in order also to look forward. Our speaker is celebrated physician and former New England Journal of Medicine editor-in-chief, Marcia Angell. Now on the faculty of the Harvard Medical School in Boston, Dr. Angell is a senior lecturer in the Department of Social Medicine and a faculty associate of Harvard's Center for Bioethics. She writes regularly these days for the New York Review of Books, and of late she's written often and quite thoughtfully on the changing social, medical, and political landscape of dying and end-of-life care in the United States. As a side note, Dr. Angell is a longtime resident of Boston, but her visit to UVA is something of a homecoming, as she went to college in Virginia at what is now James Madison University, just over the mountain. She's also happy to be here without all the snow that Boston currently has. We'd like to thank our partners in this program, Historical Collections and the Health Sciences Library, and Director Joan Exenham Klein, and the Institute for Practical Ethics and Public Life, and its director, University Professor James Childress. So now we'll have an hour with Marcia Angell, her discussion of this topic and your comments as well. And for those of you up there, there are some seats throughout the auditorium. You're welcome to come on. Welcome, Marcia.
Thank you very much, other Marcia. It is just a great pleasure to be in Charlottesville. It's a lovely place, and as Marcia said, it's especially lovely not to be in Boston. I'm going to be talking with you today about dying in America. Last year, the New Yorker cartoonist Roz Chast published a book called Can't We Talk About Something More Pleasant? And in this book, she had whimsical cartoons that featured her aging parents, both of whom refused to discuss their plans for their death, what they wanted. And in fact, as far as you can tell, they refused to consider that they would die at all anyway. So that was off the table. That was not possible. Today, I am not going to be talking about something more pleasant. I am going to be talking about death. And one reason is that death has changed dramatically, as Marcia said, has changed dramatically in just the last half century in America. And since every one of us in this room will die at some point, it's useful to know something about those changes. Before World War II, Most people died at home, and it was not a medical event. It was the existential, inevitable end of life, and it was treated, by and large, as such. Many deaths, most deaths, were not attended by physicians, and when they were attended by physicians, the physicians just made things worse. George Washington, for example, was killed by his physicians when probably what he had was a bad cold. The usual cause of death before World War II was infection, often diarrhea in children, tuberculosis in young adults, pneumonia at all ages, but particularly children and older people and the elderly. And when the infection came, death was rapid, usually within 3-4 days. All of that changed in the second half of the 20th century. And so what I'm going to do today is describe how it changed, the history of the changing, how it changed, why it changed, and the consequences. There are 3 important dates that I will emphasize because they served as sort of inflection points after World War II. So watch for those dates as they come up. The first is 1976, the second is 1990, and the third is 1997. And I'll explain why these 3 dates were inflection points later. The United States emerged from World War II with money to burn, fabulously wealthy, relatively. And one of the places the United States poured its vast amounts of new money was in medical science and technology. The NIH, which was established after World War II, grew rapidly, as did the medical schools and teaching hospitals that the NIH supported. Within a matter of a couple of decades, because of all the new drugs and technologies that poured out of the research centers, virtually no death was considered inevitable. They all had to be fought. We now had a host of new antibiotics that could cure nearly any bacterial infection, and in particular, prevent death from pneumonia. Before that, pneumonia was often referred to as, quote, the old man's friend, close quotes, because you could count on it bringing about a fairly quick and peaceful death in patients who were at the end of their life from some other fatal illness. In addition, by the 1970s, we had dialysis to prevent death from kidney failure and transplantation, artificial ventilators to do the work of breathing, new drugs to support blood pressure, methods of cardiopulmonary resuscitation to maintain heartbeat, effective artificial feeding, and so forth and so forth. As a result of all the new technologies, dying patients might lie in an intensive care unit for weeks and even months, hooked up by tubing to 4 or 5 different support and monitoring devices, with antibiotics to suppress the bacteria that would in earlier days have entered the body through the tubes or through the general immobility. In short, death became medicalized. No longer do people die at home in a matter of days, but in hospitals in a matter of weeks to months, often in great misery, not so much because of the fatal illness as because of the treatment. I was a medical student and resident in the 1960s. Dying was hardly mentioned in medical school and training programs, except as a failure of treatment. So you would be taught if you don't treat heart failure in this way, the patient would die. If you don't treat pneumonia with this kind of antibiotic, the patient will die. It was sort of this threat that followed inadequate treatment. But it was not taught as a process on its own or what it might mean for patients and their families. It simply was not spoken of except as a failure. It wasn't spoken of with families, let alone patients, who were never in those days thought to be denied hope of recovery, no matter how impossible that recovery was. They were supposed to have hope for recovery, no matter how dire the prognosis, and so they relied. Sometimes, when patients were in obvious misery at the end of life, doctors would increase the dose of morphine with the expectation that it would hasten death, but they usually didn't consult with anyone about it. In fact, the order for a large dose, an unusually large dose of morphine in those days, could lead to trouble, even then. And so if doctors decided to up the dose of morphine to bring about an earlier, more peaceful death, it was more a reflection of the doctor's philosophy, compassion, courage, than it was of the patient's needs and desires. The patient was not consulted. Now, there was beginning to be some attention to the issue of protracted death in the 1950s and 1960s. For example, in 1957, Pope Pius XII said that, quote, extraordinary medical treatment was not required by the Catholic Church. But within the medical establishment itself, there was virtually no recognition of this problem. Indeed, in those days, withdrawing life-sustaining medical treatment or artificial feeding would have been considered tantamount to euthanasia. From time to time, life-sustaining treatment could be refused, but once started, it could not be withdrawn. And there was something special about artificial feeding, or there was considered to be something special, that meant that it should be continued no matter what, even when other treatments may have been refused or not started. All of that began to change in 1976, that's your first date, as a result of a lawsuit filed by the father of a young woman named Ann Quinlan. This was the first and most celebrated right-to-die case in the country. Ann Quinlan was a young woman who had been partying. She took some Valium, she drank too much, and she was found unconscious and without respiration. Nobody knows how long. She was resuscitated, taken to the hospital, but she was irreversibly brain damaged. She simply never regained consciousness. So what to do? She was hooked up to a ventilator, she had artificial feeding, and after a few months, when it became clear that she was permanently unconscious, her parents asked to have the ventilator removed, which in those days, as I say, would have been considered tantamount to euthanasia. So they had to go to court. They went to the hospital. They said, we would like to have our daughter removed from the ventilator. And the hospital said, no, we can't do that. And they went to court, and it went all the way up to the New Jersey Supreme Court. The father was appointed guardian, and the court, in a remarkably impressive decision, said the father had a choice. He could either remove the ventilator or not remove the ventilator. That was up to him. And so they said the only condition was that what they called an ethics committee had to agree that it was a hopeless prognosis. And really, this was a prognosis committee, but that is and I forgot to turn it off. And this is my daughter, the doctor. So they said that a prognosis committee had to agree with the prognosis, and if they did, if it truly was irreversible, then Quinlan's father would have the right to remove the ventilator if he so chose, which he did choose to do. So the ventilator was removed. But because there was something different about feeding, he and his wife would not remove the feeding tube. And it turned out that she did not require the ventilator to survive. So she lived another 9 years before she died, because in those days, artificial feeding was considered something more sacrosanct than, say, the ventilator. The Quinlan case launched a remarkable 14-year period between 1976 and my second date, 1990, in which the right to withhold or withdraw, we'll come to the distinction a little later, but the right to forego life-sustaining treatment became almost universally recognized in this country. That is a very rapid change of opinion. Within 6 months after the Quinlan case, now I should say that going back to Quinlan, most of you were not cognizant in 1976, in one way or another, but everybody who was cognizant in 1976 knew about Karen Quinlan. Her photo, same photo, was on the cover of every news magazine, every newspaper. There was not a dinner party that occurred in 1976 in which her case was not discussed. And what was said at all of these dinner parties was the same thing. Don't ever let me live like Karen Ann Quinlan. Everybody said that. And the country listened. So within 6 months, California's always first and everything, California passed the first Natural Death Act, the first state Natural Death Act. And that gave doctors immunity for following the directives in living wills, within limits. There were some restrictions. But if a living will existed that said, I would not want a ventilator in such and such a circumstance, and the doctor went along with this, he was protected by doing so. All 49 other states, one after the other, boom, 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 in the next 14 years, passed similar versions, similar natural death acts. And this culminated in 1990 with the U.S. Congress passing the Patient Self-Determination Act of 1990. So this was federal. It became the law of the land. This required all facilities, all hospitals and health facilities that received federal funding, and that's just about all of them, to inform patients on admission of their right to refuse any treatment for any reason whatsoever, or if they weren't capable of making this decision themselves, to prepare an advance directive and or name a proxy to carry out their wishes. So that was all. 1990 was important for that reason in the evolution of how we die in the United States, but it was also important because the U.S. Supreme Court got involved that year for the first time. And this was in the case of Nancy Cruzan. Nancy Cruzan was a young woman very much like Karen Quinlan, who had the same sort of an accident, and she was resuscitated. This was in Missouri. She was resuscitated, and it was found that she was in a permanent vegetative state, permanently unconscious, like Karen Quinlan. She too was on a ventilator. She too was getting artificial breathing. And her parents asked to have the ventilator removed, and Missouri was a little bit, and feeding tube. Her parents asked for both to be removed because that had changed too. And I'll get to why in a minute. But they asked to have all life-sustaining measures stopped. Missouri said that they would not do it unless there was clear and convincing evidence that this is what she would have wanted. Now, Missouri was one of just 2 states that required that would not let a proxy make that decision. And so it went before the U.S. Supreme Court, and the U.S. Supreme Court sided with Missouri, said, yes, that is the law, the state law of Missouri. There has to be clear and convincing evidence. But at the same time that they denied the parents' request, they were extremely sympathetic. And they said that in other states, or if there had been clear and convincing evidence, then a person had a right to refuse life-sustaining treatment either directly or through proxies. Now, this was 1990. The ethical underpinnings to this case owed much to the 1983 President's Commission for the Study of Ethical Problems in Medicine. This commission published a volume, one of many volumes, called Deciding to Forego Life-Sustaining Treatment. And this had an important effect on the medical establishment, the medical community, and medical ethicists. They said that there was no ethical distinction between refusing and withdrawing treatment, that you didn't have to worry about starting a treatment that you might later want to withdraw. That was a real problem. If you had a distinction between refusing or withdrawing, then there were probably a lot of people who didn't have treatment started to be given the chance of recovering. So they said there was no ethical distinction between refusing life-sustaining treatment and withdrawing it once it began. And they also said, the President's Commission, that there was no ethical distinction between artificial feeding and any other medical treatment, that they should all be regarded the same. And so that really did inform the Supreme Court in the Pouzin case, which said the same thing. So then what happened after 1990? Now, there had always been a small movement that favored assisted suicide or euthanasia. And let me just take a brief digression here to make the distinction. In assisted suicide, physician-assisted suicide, the physician prescribes a lethal dose of a medication, usually a barbiturate, perfectly nice, peaceful death, usually a barbiturate, but the patient must take the drug himself or herself. The physician plays no role in it other than writing the prescription. Whereas in euthanasia, the physician actually administers the medication, usually an injection, a lethal dose of barbiturate. So that's the distinction. And we'll come back to that later. So there had always been a small movement that favored assisted suicide and or euthanasia. But it had little impact. It was well outside the mainstream of medicine. It was considered disreputable. And one reason is that when it began, it had the unfortunate name, the Hemlock Society. I think people found it a little bit creepy in those days. The essential argument of this movement was this: hastening an inevitable death by foregoing life-sustaining treatment, such as a ventilator or artificial feeding or dialysis, discriminated against those who were equally in need but didn't happen to require some life-sustaining technology to live for the next day. So there was nothing that could be withdrawn, even though they may have been fatally ill with a disease that caused just as much suffering. For example, a patient with metastatic lung cancer might require a ventilator in order to survive another day. But someone with metastatic cancer of the pancreas, for example, who was just as near death, who was suffering just as greatly, might not be on the ventilator. So what were you going to remove? So the argument was made that this was discriminatory, that people who wanted to die just as much and whose prognosis was just as bleak somehow could not do what other people could do, who could refuse or withdraw a ventilator or refuse antibiotics or refuse dialysis. So this was this movement, this fringe movement, was sort of going on sub rosa, but well outside the medical establishment. It wasn't until 1990, again, my second date, that the issue began to have traction. And that was because of the emergence of two influential proponents of assisted dying, essentially a bad cop and a good cop, whose activities captured the media and also the attention of medical ethicists. The bad cop was Dr. Jack Kevorkian. Kevorkian was a pathologist who in 1990 set out on something of a crusade to help people end their lives. These people, and he went all around the country to do this, these people were by and large strangers, people that he was not a clinician, he was a pathologist, were strangers with disparate ailments. Some of them failed, some of them evidently not. They may or may not have been terminal. And he put together contraptions for them to end their own lives. It was suicide, it wasn't euthanasia. But he set up these elaborate contraptions where the patient could trip a lever and it would inject the barbiturates, or trip some kind of a lever and release carbon monoxide. Some of them died in that way. And according to his lawyer, he helped 130 people kill themselves in these ways. It's interesting that, and I'll tell you later, that 36 states at that time had laws on the books against assisted suicide. Michigan, Kevorkian state, did not, but they rapidly passed a law precisely to stop Kevorkian. Kevorkian was then brought before juries, indicted, brought before juries 4 times, and each time the juries refused to convict him. Because even though most physicians, medical ethicists were appalled at what he was doing, there was a lot of public sympathy for him, and the juries refused to convict him. So that's the bad cop. The good cop was Dr. Timothy Quill, an internist in Rochester, New York, who in 1991, the next year, told in the New England Journal of Medicine the compelling story of his decision to provide a patient with drugs to end her life if and when she chose. Now, this was a patient, he was an internist, he had been her physician for 8 years, she was 45 years old, she had leukemia, her only possible hope was bone marrow transplantation, and even then, most of her physicians thought that she was not likely to survive. So she declined the bone marrow transplantation. She said, I would rather not have it, I would rather not die in that way, but what I would like, Dr. Quill, is for you to give me a prescription for an overdose of barbiturates to use if and when I'm born. And so she did. He called this patient in his article Diane, and he gave Diane a prescription for an overdose. And she did use it. She had a husband and an adult son who were very supportive. And when she decided it was time to end her life, she told them to take a walk for an hour. And when they came back, she was dead. He published a story in the New England Journal of Medicine, as I said, and like Quinlan, Kevorkian became a household name, and while Quill did not become exactly a household name, he became very well known within the medical profession and the profession as a whole had quite a bit of sympathy and support for what he did. Now, as I said, at the time that Quill did this, 36 states had laws against assisted suicide by the doctor or anyone else. Didn't matter who did it. There were laws against it. And New York, where Quill was, or Diane lived, was one of those states. I was executive editor of the New England Journal of Medicine at the time Quill submitted his paper. And I read it, I think it was on a Friday afternoon, and I thought it was a very good paper. But I also was aware of the possible legal implications for him, and I wasn't sure that he was. So I phoned him up and I said, I really like this paper, and I'm willing to publish this paper, but you have to think about what you're going to do, and maybe talk to attorneys at the hospital, talk to friends, decide whether you want to take what I think is some risk. And we can regroup next week and decide what you do. And the next week he said, I want to go ahead. And we found out he knew what the risks were, and he said, I want to go ahead. So we published it. Almost immediately, the county district attorney brought Quill before a grand jury to indict him for manslaughter. After a harrowing 3 months in which the grand jury was hearing the case and these things were going on, they refused to indict him. Much like the juries in Michigan and Kevorkian, they refused to indict him. And then he became a national spokesman for assisted dying as a last resort in dying patients. And he immediately turned around and sued the state of New York. He said this was a violation of the 14th Amendment, the Liberty Clause in the 14th Amendment, and he sued to overturn the law. At the same time, a similar suit was carried out in Washington State against the Washington law that also prohibited assisted suicide, and both of these cases started to wend their way toward the Supreme Court in the early 90s. In both states, the appeals courts, went first to the appeals courts, and they sided with the state. I'm sorry, I have this wrong. The appeals courts sided with the plaintiffs. The appeals courts overturned both state laws, both in New York and in Washington. And then the states appealed to the U.S. Supreme Court, and it wended its way to the U.S. Supreme Court, which eventually reached in 1997. Meanwhile, as this is going on, a few years earlier, in 1994, to almost everyone's surprise, the voters in Oregon passed a Death with Dignity Act by a voter referendum that would permit physician-assisted suicide under certain stringently limited conditions. This was a surprise to everyone because these ballot initiatives had been tried in other states and failed. They'd been tried in Washington State, tried in California, and they failed. And this was just one of these, we'll try this, a sort of Hail Mary pass. And it passed, narrowly, but it did pass. It was stayed for a number of reasons. I won't go into the details of the reasons, so it was not put into effect immediately. The Bush administration tried to stop it. It said it was a violation of the Federal Controlled Substances Act because you would have a controlled substance used in this way. So all of this was kind of held in abeyance while the Supreme Court was considering these two cases. And in 1997, that came to a head, and this is the third day to remember. The U.S. Supreme Court did reverse the appeals courts. That is, it upheld the laws in New York and Washington against physician-assisted suicide. It said there was no constitutional right to physician-assisted suicide. But in spirit, it was very sympathetic. Just like the Cruzan case. I didn't mention that the end of the Cruzan case, they said that she had not left clear and convincing evidence. And then a bunch of her friends said, oh, she told me one time that she didn't want to live like Ann Quinlan, and then the court said, oh, okay. And so they were able to withdraw the life-sustaining treatment. But anyway, the Supreme Court, again, in 1997, was quite sympathetic, particularly Justice O'Connor, Sandra Day O'Connor. She said that she was unwilling to find a constitutional right at that point, but if pain were undertreated throughout the country, she might be ready to revisit that. And what she also said was this is a matter for the states, the laboratory of the states. The states could do what they needed to do. And that was a signal to Oregon. Oregon, since 1994, had not done anything. Partly they were fighting the Bush administration. But when the Supreme Court was sympathetic and said this is up to the states, Oregon then decided they would have a do-over. They would have the referendum again. And opponents thought that maybe this time people would come to their senses and vote against this Right to Dignity Act, and they did just the opposite. I think the Oregonians didn't want the feds telling them what to do or something, but they passed it overwhelmingly 60-40 in 1997, and it went into effect in 1998. So exactly what is Oregon's Death with Dignity Act? Well, what it says is that a competent adult cannot be done through an advance directive or through a proxy. They have to be competent at that moment. That a competent adult who is terminally ill, as certified by 2 physicians, and has a life expectancy of no more than 6 months, can choose to get a prescription. Doctors can write a prescription for barbiturates, that's what they use in Oregon, to bring about a quicker, more peaceful death, if and when the patient chooses. The patient has to make 2 oral requests 15 days apart, and 1 written request with 2 witnesses. There is to be a referral to a counselor, a mental health counselor, if either physician believes a psychological disorder is causing impaired judgment. Now note that it has to be serious enough to impair judgment. It can't just be the usual depression you might see in a dying person. Detailed records are kept by the Division of Public Health in the state. Every year you can go to their website and find out exactly who has used this law, how many people, what their reasons were, and I would recommend you do this. So what has happened in Oregon? Well, the law has now been in effect for 17 full years, and it seems to work exactly as intended, despite all of the concerns at the time it went into effect. As of the end of 2013, there were over 1,100 prescriptions written for the lethal dose of barbiturates, but 1/3 of these patients don't use it. They keep it on their bedside table because it provides peace of mind. But the other 2/3 did use it. There were 752 deaths, or 1 in 500 deaths in the state of Oregon. The most common diagnosis is metastatic cancer, over 80%, and most of the rest have, many of them have end-stage emphysema, stage 1 disease. Some of them have end-stage amyotrophic lateral sclerosis, but most have metastatic cancer. Now, the concerns were that there would be coercion to have people use this law, that it would be used primarily by people who were alone, by people who were uninsured, by people who were poor, or people who were in some ways uneducated and easily influenced by people who might want to inherit their property. All of these concerns were there. And it's turned out to be completely different. The great majority, first of all, are receiving hospice already. That was one of the concerns. They're receiving palliative care. The great majority are better educated than average, more affluent than average, and well insured. And when you think about it, that sort of makes sense. These are the people who want control over the circumstances of their life, the kind of people who are educated and affluent. And in fact, when asked their reasons, the most common reason was loss of autonomy and dignity. Pain was there, but it was not at the top of the list. Inability to engage in meaningful life activities, these existential reasons. Most of them, almost all of them, died at home, which is where most people say they want to die, with their loved ones present. Now, it's important to know that in Oregon, patients have a choice. Nobody is told they must do this, and doctors have a choice too. And most doctors, when they're asked to do this, still refuse. But there are doctors who do it, and it's completely a choice. The fears about palliative care have not been borne out. It was thought, well, one problem. This is something Atul Gawande says in his book, Being Mortal. One problem is that this could become a substitute for good palliative care. The state could say, oh, we have assisted suicide, so we don't have to worry so much about palliative care. But in fact, it was the opposite. There was almost a competition between the people in Oregon who thought that palliative care could relieve all suffering and the people who felt that autonomy was important. And so palliative care improved greatly in Oregon after the implementation of this law. There's something called the Center to Advance Palliative Care, which in 2011 published ratings of the various states, A to, I don't know, D maybe, in terms of the quality of their palliative care. Oregon was an A, and my state of Massachusetts was a B. They also have found that there's no more depression in patients who request assisted suicide than in other terminally ill patients, as far as we can tell. So there doesn't seem to be a slippery slope there. In 2008, Washington State enacted the same law with a referendum that it had failed before, but now it passed. And 2 other states have now legalized assisted dying. Many people prefer the term physician-assisted dying to physician-assisted suicide to distinguish it between the case of a person with a normal life expectancy who then chooses death over life. And the argument here is they're not choosing death over life. They're dying anyway. So they're simply choosing the precise time and manner of death. So a lot of people insist that it be called physician-assisted dying and not suicide. I'm not too hung up on the wording. We all know what it is. But Montana and New Mexico have both legalized it through the courts. The courts in both states said that this is a fundamental right. And Vermont, the year before last, legalized it through the legislature. So there are now 5 states in the state. It was narrowly defeated in Massachusetts in 2012 as a referendum, very narrowly defeated. Now, note that these laws apply only to physician-assisted suicide, not to euthanasia. There are other countries that recognize physician-assisted dying. In Switzerland, it's the same as the United States. They recognize physician-assisted suicide, but not euthanasia. But in the Netherlands, Belgium, and Luxembourg, they make no distinction between assisted suicide and euthanasia. And in fact, euthanasia is more common simply because it's faster and easier to do. You don't have to swallow all those pills. So before I wrap up, I'm almost ready to wrap up. Full disclosure, I was the first of the 14 original petitioners in the effort to legalize physician-assisted dying in Massachusetts, to get it on the ballot. And I've long favored physician-assisted dying. And we can discuss this in discussion if you would like to, but let me just briefly give you my reasons. It's often said that doctors should engage only in healing, and I think that's great, as long as you can. But it seems to me that when healing is no longer possible, when doctors can't meaningfully prolong life or quality of life, then the overriding duty of physicians is to relieve suffering, and to do that in accord with the patient's wishes. And the notion that someone can presume to tell someone else how much suffering they have to endure at the end of their life bothers me a lot. It seems to me this is a patient's business. As I said, this isn't a matter of life or death. It's a matter of the exact timing and manner of death. Not all suffering can be relieved, despite the best efforts of palliative care doctors. Pain can usually be relieved, but other forms of suffering are much more difficult to relieve. Weakness, shortness of breath, nausea, just the existential suffering of knowing that each day is going to be worse than the one before, and you just have to keep plodding on, soldiering on, in an inevitably downhill course. So that is a form of suffering. Atul Gawande, in his book, Being Mortal, Medicine and What Matters in the End, talks about the modern technological imperative to prolong life, and he says this, quote, "We imagine that we can wait until the doctors tell us that there's nothing more that they can do. But rarely is there nothing more that doctors can do. They can give toxic drugs of unknown efficacy, operate to try to remove part of the tumor, put in a feeding tube if a person can't eat. There is always something." Close quotes. I sometimes think of a poem by Algernon Swinburne called Garden of Proserpine, and these are the lines that I recall. Swinburne said, quote, "We thank with brief thanksgiving whatever gods may be, that no man lives forever, that dead men rise up never, that even the weariest river lies somewhere safe to see." Then maybe this is a little weak, but still, we owe it to one another to recognize that we all must die. It's both mindless and heartless to try to stave it off indefinitely, no matter what the cost in suffering, just because we have the technology to do so. So thank you for your attention, and I'd be happy to take any questions and arguments.
We have quite a generous amount of time for discussion, for your comments, your views, your questions. Marcia is happy to take those. So when you raise your hand, a couple of us have microphones that we will bring to you so that your comments are on the recording, and I would ask you also to please identify yourself before you ask your question or make your comments. So I know it's a little hard to start. It's a lot to digest.
My name is Todd Cooper, and I work for UMA, a general medicine clinic. But this is probably more personally oriented. What happens to a patient who is paralyzed, who has C2, C3 break, who can't say anything, who can't write anything, that's intubated? How does that play in?
Can't say anything, can't make his wishes known?
That's right. Or is to, let's say that in order to relieve the pain, they're on medication to relieve the pain, which, in order to relieve the pain, they're on medication to relieve the pain, which dulls their senses. In order to get their senses, you have to subject them to a great pain in order to make them lucid enough to say anything. Or to nod or blink their eyes or whatever.
Well, these are the forgotten people. And in some cases, amyotrophic lateral sclerosis, it's the same sort of thing. And there is no law, none of the 5 states that have legalized assisted dying have anything to offer these people. It's just really sad. I don't know an answer.
I'm Susan, and I'm not a clinician, just a researcher. And my question is, you were saying the 5 states have approved these new laws, and so we're assuming the rest of the states have not. And from what you were telling me with the Oregon data, about like 1 in 500 people actually help themselves to die. So given that it's like really like 1 in 500 or so, how are the rest of the people dying? I mean, is there a difference in these states compared to how people, quote unquote, normally die, compared to the states that don't have these laws? I don't notice any difference.
People who are dying of a disease like cancer, a protracted death, usually have palliative care. We can hope that they have palliative care. And for most people, that's sufficient. For most people, that's sufficient. In Oregon, as I say, they have very good palliative care. There's a strong biological imperative to live. Very few people want to die. And even when they're living in the most abject misery, many people, for them, life is the most important thing. All the Oregon law does is recognize and give the people for whom that is not the overwhelming imperative the right to make a different choice, to make their own choice. So 1 in 500 people do so. Now, the law in Oregon and Washington, the conditions are very, very stringent. There are a lot of conditions they have to meet. I suspect that some of these conditions act as obstacles, and that if they weren't so onerous to meet these conditions, more people, it might be, 1 in 50 and not in 1 in 500. And I suspect it will become more common. You can see even in Oregon that it's being used somewhat more. Now, I think it wasn't used at the beginning because it was tied up in court. It wasn't until 2006 that it could overcome the Bush administration attempts to essentially punish doctors for prescribing under that law. And then, since then, it's been used more. I think it will probably continue to go up. But the conditions now are very stringent.
Marcia Angell, Public Health, thanks for being with us. The discourse we're having today is unfortunately the exception rather than the rule. As you noted, only 5 states have taken any action. With the aging of the baby boomer generation, this issue is going to become more and more profound. What are your thoughts about how we might expand the discourse around this issue of dying in America?
I think it will happen for precisely the reason you say. Atul's book is not just about dying, it's also about aging. And one of the things about the baby boomer generation is that it's a big group now aging. not the old yet, but rapidly getting there. And they haven't saved any money. They're used to kind of living in the present. So what is going to happen when they all have to be in retirement communities or nursing homes? It doesn't take them very long to spend down and need Medicaid. The government is strapped because of the costs of Medicare and Medicaid. They are also used to having a lot of control over the circumstances of their lives. I suspect that this will be talked about plenty, and we might see other states do it. Now, this would be for the worst possible reason. I think it is for the worst possible reason. But I think it will put it on the agenda to discuss.
Hi, my name is David Bruns. I'm a former journal editor, and I'm very happy to see from your presentation that there is life after editing.
I took a lot of naps at first.
I'm a pathologist, and my question has to do with, I'm not related to Dr. Kevorkian, but I'm on the laboratory side. My question may be sort of trivial in a way, but here it is. We know that there are conditions under which treatment can be withheld. How about testing? We seem to do a lot of it.
Well, we do way too much testing, and the reason is that testing and procedures are preferentially rewarded in our crazy health system, so the more you do, the more you make. But there's now a move to, it's very tentative and it's hard fought, but to say men shouldn't be getting PSAs routinely, that women maybe shouldn't be getting mammograms until they're 50, that colonoscopy should be maybe every 5 years, maybe every 10 years. So there's a movement, I think led largely by Gil Welch at Dartmouth, to say no, there's too much of what's called preventive care. And it leads to trouble because you can find stuff that you're better off not finding. I think that is a real issue, and we do too much testing.
And at the end of life, when treatment is withheld, you can stop testing as well.
Well, yes, although if you're in a hospital at the end of life, you're going to do blood draws a couple of times a day anyway, just because you're there. So there's a certain mindlessness to it.
Hi, Deanna Settlemarker, BSN and D&D at the School of Nursing. My question is about life insurance. Usually suicide is a discriminator for payout for the families with life insurance policies. Can you speak to the physician-assisted death and life insurance?
Yes, the cause of death in Oregon and Washington and Vermont. Now the regulations haven't yet been fully written in Montana and Mexico. But the cause of death is the underlying cause. It is not suicide. And it is illegal to withhold life insurance.
My name is Mark. I'm a physical medicine rehab resident. I read Dr. Gawani's book, and one of the interesting take-home messages I got was that he sort of laments how late in the game palliative care and hospice care is involved, and how that could probably be done a lot earlier, but there is a negative connotation to it, or sort of getting up associated with it. If you could comment on how you see that changing going forward with not even just terminal cancers, but end-stage heart failure, emphysema.
Yeah, I think there are two things going on there. One is that it's still true that doctors are very reluctant to tell patients how dire their prognosis is. And so the patient has unrealistic hopes. And the doctors, and the tool shows this, the doctors too, not only are afraid to tell the patient straight out that, I don't think you're going to live much longer than the summer or whatever it is, but also they have unrealistic hopes. He cites a study at the Mass General Hospital in which physicians are asked what the life expectancy is of their patients with fatal illness. And I think they, on average, estimated it 5 times longer than it was. So nobody knows how bad it is. The other thing is that Medicare will pay for hospice if you say your life expectancy is no more than 6 months. And so people are afraid to live longer than 6 months in a sense. And so there have been studies showing that people don't enter hospice. The last one I saw, maybe that's no longer the case. I think we're better about this now. But it was something like 1 week before death. That is way too late. But I think that there are 2 reasons.
So speaking of way too late, our time is up. But I'd like to thank you for this very thoughtful and informative and thought-provoking hour.